they came that. So one of our studies was that we can do multimodal therapy. In fact, a lot of people what they do is they especially go for cancer is if it's a solid tumor they need to get a surgery, then they follow chemotherapy, then they follow immunotherapy, a sequence of things basically. But what we really talk about, there are certain cancer you cannot do surgery, blood cancer for example, so there is no surgery. Directly start with this chemotherapy. So when you do chemotherapy, a lot of side cells also get damaged, right? Essentially not only the bad ones, but good ones also do. So then immunotherapy kind of activates the immune system. So essentially what is found out in a good way, that you can start all these things together. You don't have to wait chemo to be over, then you start. So that was our study basically, whether that is right or wrong, we never did anything that way. Then I was looking for something else where the control system will operate 24/7. And then diabetes is a fantastic problem, especially those type 1 diabetes, where you talk about automated insulin delivery. I didn't even know that it was called artificial pancreas. It is simply called blood glucose control, that's all it is. We started with doing that and little fun exercise, and then one thing led to other, then some posters joined. Then we that is the same is actual faculty in IT Madras now. So we did something there, and then one thing led to other, then I got little more interest, little more success. Then at a point came when we actually talked seriously. Then that is the point we got some funding very good way. In fact, couple of my initial plans were rejected because we are talking aerospace and biomedical areas was not complicated. So in fact, our IISc internal system rejected once for me. That's I don't know how many people are aware of it. Then Indo-US Forum rejected once, and then finally came this opportunity of April thing. That completely changed the world. So then we got very well funded, and then we got associated with clinical people. Ms. Ramaya, Dr. Mala was there at one time. And then from there onwards, a completely different ballgame. We also got supported by Dr. Ananta Basu, which is not forgetting, that they have done quite a bit of research in that Mayo Clinic in Virginia Tech, now there in Alabama, in US. And he actually gave it out, we established quite a good relationship. And all our clinical studies are based on their failures or something. In other words, whatever they have done it, they have actually guided not to do that same thing. So we will kind of prevent ourselves before we go to the post basically, right? That way. So their contribution is immense also. So we got an ecosystem built around that. Then again, after there was a time when many people actually did not want to do what we were talking about diabetes research. And thanks again, that is exactly God is good, God is great. So IISc joined at that point in time. After 1 year, Divya joined, then we completely different work. That's how it is.
The journey is so nice to hear. One led to the other, and today we are here launching a product. So the same mathematician that keeps an aircraft stable can also keep diabetic patients stable. Let's talk about that patient, right? You have interacted with hundreds of patients beyond the numbers. What are the biggest day-to-day struggles an Indian diabetic patient faces?
Okay, so before I answer that question, just because excited that let me complete the story. When you talk about control system can solve others' problem, you don't really simply go there like a Bundas or other. So we're not fighting for you. We're actually kind of struggling with them basically, right? So actually understand their problem first. When that is why I keep on telling them, you can migrate from discipline to discipline, but take your time to study the discipline to best extent possible. Otherwise, understand before you control. So that is what it is. So when you go into biomedical side, the same theory, actually theory part is same, but the concerns are very different, capabilities are different. So in aerospace we talk about millisecond level control, otherwise you are not interested, because before you realize the mission control is over. So your control system update happens in few milliseconds. A millisecond means what? Before 1 second you count 1,000 times, no? That is 1 millisecond. So we talk about 20 millisecond update, that's what we need, 10 millisecond update. But these things are actually not required in biomedical, because it's very minutes of data. So there are certain things there. And then also talk about what are the difficulties here, because in man-made system, be it robotic, be it aircraft, be it missile, be it Chandrayaan also. Once we build the system, more or less everything we know. We know how much is the mass, how much is the moment of inertia, how much is the CG, how much mass will be going, how much thrust will generate, which direction it will go. Also, how much is the gravity of the moon. All that we take into account and build an autonomous system, right? But here is a system in biomedical system. You are not in control of it. God is giving you a system, right? So essentially, even if I know it's a human body, now your metabolism is very different from my metabolism. So that means that variability is very, very large. And that is a good thing that God has given me. Because if variability is small, all of us would not be sitting here. COVID time will all be portrayed only here. So that way, basically. So the variability is good for survival. But then it is good for, very difficult for control system person to operate. Because now we talk about large uncertainty. Then also, all these man-made systems, you get sensors very fast. If you take control action in 10 milliseconds, sensor data is available in 5 milliseconds. Very, very quick. And then you talk about our aircraft when you go there, right? It is very, very well instrumented. And each of the sensors will talk about three triple redundancy we call. So three sensors are there for every parameter, for reliability point of view. Here, none of that is possible. So we talk about no reliability. I mean, suppose our diabetic metabolism, we talk about something called minimum model. Minimum model is 8 different hormones are working together. Here, the sensor that is picking out is not even that. It picks up the 9th one. So that there is a correlation between that from which you recover. That means the signature that you get in the sensor for your metabolism is very, very weak. So all that thing that is, there are certain good things, there are certain bad things. So you have to study that system first, then apply your knowledge and carry forward. So that is the similarity, non-similarity, whatever. Now coming to your question finally, talk about it, difficulty. Well, every patient will be fed up. I mean, that's the whole thing. It's not that simple. One thing about diabetes, Dr. Sekondam agree probably, diabetes people do not know that they are having diabetes. Because they don't get the symptom unless it is, when you get something that is bad already, whether you got a stroke, you got some foot ulcer, you got something, that is too late already. So, because the process of development is very, very slow, and during that process, people think that I am here, nothing is happening. Because we don't feel it. I mean, genuinely you don't feel it. Maybe a little bit tired, you do something, you feel it, but otherwise, yeah, fine, what is happening? I can take a sweet, one bite can I have it, and one sweet can I have it, okay, that becomes habit, right? That kind of thing. So this compliance, the patient compliance is actually a very big problem because there is no pain in the body. There is nothing happening in the body. Right? All that will, because people will tell you about blood glucose is high. Or, right, that is what it is. Unless you go to hypothyroidism. Hypothyroid is not, normal doesn't happen unless you are already diabetic, doesn't come. So the people who are pre-diabetic, getting to diabetic, things like that, they don't even realize, in my experience, that there is diabetes. So people say nothing left in you. Whatever, what left in, I'll see later. So this kind of attitude is very normal, it is very, very human, because what will happen 10 years later, why should I worry about it now? So patient compliance is a major issue. Second issue is availability of resources in a cheaper way. We were having a session after this. People know that there are solutions, but I cannot afford it. So whatever affordability I can just go with that. Everybody given a choice, everybody like to operate insulin pump, but insulin pump is very expensive. Type 1 I am talking about. But then it is very expensive. Pen is fine. Okay, just talk about a pen. So there is affordability factor, there is availability factor. There are also for example, another thing is dual hormone pumps. I don't know how many people know about it. Every insulin pump comes with a glucagon component also. That is already started happening in US. But then the glucagon is not needed first of all. It's needed only in emergency. Not every time you need it. And then glucagon is not stable. So that means if you cannot talk about room temperature basically. So that little insulin pump you cannot be refrigerating there. So every time you replace that, there are a lot of other issues there. So there are a lot of different things that happens there. That is why diabetes is very important. Next problem requires continuous monitoring, requires not only you but some caregiver support. And then doctors, if they want to treat them, any patient, well, they have to spend time to understand all that. The time means there are so many patients there, how much time they can give. I mean, that is also a problem, practical problem. So there are many issues because of which there is a big problem.
Thank you, Professor. Since you already started talking about the SugarSight product, can you explain how does your IoT-based diabetes ecosystem work?
I've given a small presentation already, so people probably know about it. So it was actually, when we started doing this, honestly speaking, when I started about 2010, I didn't even know that it's called artificial functions. I was just hunting out for my associate professor to full professor promotion, so to 2 more publications. I am good with it, right? Because then people will come to publications. It doesn't matter where you publish. IISc is fantastic. You can do whatever problem you want, they will just talk about whichever discipline doesn't matter. So many number of publications with journalism. So in that context we started. But then having said that, when we started taking serious turn and all that, thanks to IISc again, it completely revived the field. And then we become very serious. IISc, by the way, also comes from aerospace. I don't know how many people Dr. IISc is there in the stall and all that, you can see also comes from aerospace. So we actually gel very well. That's the last person there. So that he comes from drone, by the way. So essentially our but the question is not that. Question not that is sufficient. We now talk about doing deeper and deeper things. So one thing not about just the morning cycle. Once you started morning cycle, there's a lot of failures. Sometimes sensor will fail, sometimes something happens, sometimes the sensor quality is not good, sometimes you put the phone directly there and then the phone itself, then the sensor itself, sensor fails. Many things that happen and it can lead into a frustration loop, by the way. So that is also there. We overcome that somehow. And then we talk about, well, this is too many things to do. That means, first of all, we started with glucose water, morning glucose water, 80 grams of glucose water, something. After we tried several things, just before the project ends in March 2022, we got some nice 2 successes. The project was extended 3 years to 5 years because of COVID. I think thanks to COVID or not, I don't know. But because of COVID, it got extended. We got the fantastic result in the last month of our 5-year project, and that motivated obviously a little more. Then we talk about now glucose water is not sufficient. Nobody drinks a glucose water. So can you give something more? They talk about, yeah, we talk to Dr. Malay, we talk about something called NCL Plus. It's a diabetes food insulin. So NCL Plus is also glucose, but it also comes with little protein, fat and all that. So we migrated to that. That works. Then we talk, no, nobody talks NCL Plus. Can you really give idli vada? So that is actual breakfast. That also happened. Then in the current phase that we have gone to Chennai basically. So there we are talking about actual South Indian food. Because they have got a calibration look and all. So one thing leads to other. Then we talk about, well, everything is done, then what about exercise? Somebody pointed out. So exercise also we talk about something there. Unfortunately, these are very expensive. By the way, see, one of our closed loop trial talks about a week, and one trial, whether it is success or failure, we end up spending about 1 lakh rupees. And that one trial, basically. So that is almost 89,000 pounds. So because patient has to come twice, they have to go hospitalization, you have to pay for their bills, you have to pay some all insulin, all expenses, or sometimes sensor will be 3-4. So all that expenses taken together is a very time-consuming exercise. Again, thanks to India, again they are there also. I didn't know that. Alright, so essentially it's a very complicated loop, so it's not that easy. So that is why this particular research in the clinical trial setting is very rare in the world. And in fact, we are the only one in the country probably because we have been somehow fortunate successful to do this. Otherwise, it's just too much of a thing to ask for because the clinical trials also. Do a little bit quicker test, multiple tests is possible. We just talk about a sensor test. That multiple things, give a lot of sensors, people generate the data, give you the data. That's the easier part. Then there comes the closed loop part. Closed loop part is again I'm talking about variability, right? 2 days back you take the blood sample, get everything, control system fitted, all these things customized. 2 days later you go, patient variability is there. That control system what you actually designed for doesn't work after 48 hours. So that way, then you talk about why it doesn't work, then you talk about changing it down. So can you really change it down? That means there is some sort of AI loop which will keep on tuning to your body dynamics. Now whatever you tune for day 0, it will keep on learning from whatever model is predicting, whatever sensor is giving. So between that error, it will keep on learning your model parameter customized to that. That is also not sufficient. Then you talk about that is not everything. So there are other parameters, right? How to do about that? So I talk about something called uncentered, there is some, in our theory there is something called carbon filter. There is carbon filter, extended carbon filter, uncentered carbon filter, all that are there. So there is no probably that way. So the uncentered carbon filter is something like a Gaussian distribution we talk about. So parameters that are not accurate, but mean value is available. Some value I got it, but it can be anywhere between that. That range is there. So you talk about each of the parameters, you got minimum value, maximum value. I got a number, but it can be anywhere between that. That is all of biomedical papers are also like that, right? Plots are there, dots are there, there is some bar into it. That means I don't rely on my value, bar can be anywhere, right? So that means all these parameters that I am talking about will have this plus minus value. Then we figured it out, there are four parameters like that. Other